My name is Leah, and I am the brand manager at Ellenhorn. And I would like to welcome you to the Community and Connection Ellenhorn and the Menninger Clinic series at 2021. We are very excited to have you with us today. Before we get started, I just wanted to do some quick housekeeping things. So we do ask that while our speakers are presenting, you keep yourself on mute. This presentation will be recorded, so if you don't want yourself to be recorded, just keep your video off. There will be times where our speakers open it up for discussion and questions, so feel free to unmute yourself, turn your video on, and chat. And now I'm going to turn it over to Meg Horn at the Menninger Clinic.
Hi everyone, I'm Meg Horn. Thanks for coming. I just wanted to mention a little bit about the Menninger Clinic. If anyone is unfamiliar with us, we're a specialty psychiatric hospital located in Houston, Texas, and we treat complex patients. We offer assessment services and a longer length of stay for inpatient care. And I'm going to put my information in the chat box if anybody wants to chat about services for Menninger. So thank you. Thanks, Leah.
No problem. So I am going to introduce our speakers. Today's talk is Demystifying Integrative Treatment for Co-occurring Disorders, Helpful Strategies for Helping Professionals. And our speakers today are Vaughan Gilmore, LCSW, LCDC, who is the Director of Addiction Services at the Menninger Clinic, and then Zoe Andalcio, LMHC, who is the Director of Addiction Services at Ellenhorn. So I'm going to pass it over to them.
Thank you so much, Leah. Good afternoon, everyone. We are so pleased to be here. I'm so pleased to be here, especially with Vaughan Gilmore. This is our first time actually presenting together. And so I am really, really excited about this collaboration.
Yep, same. Super excited to be here. Thanks.
And I didn't realize we had so many camera shy people who don't want to be recorded, but it's okay, I guess. Well, why are we here talking about integrated co-occurring treatment at a talk series about community and connection? Well, we've all kind of seen on TV or in the news, news reports about, like, let's say there was a shooting, or let's just say something terrible happened in the community. And we've seen this sort of style of reporting where basically, the context is left out of why, this terrible thing has happened. And so this is, we kind of call it like biased reporting, where the conditions surrounding the incident are not explained to give a frame of reference. It's all kind of about breaking news or not really telling a complete story. Well, an analogy of that in the addictions world is when we only focus on the addictive behaviors of a person, and we completely sort of ignore that there are all these social things happening to a person. And we completely ignore that there's a whole person in front of us. And so this whole person includes the psychiatric things that are going on, but also the social and economic conditions in which this person is living. In public health terms, when we think about social and economic conditions, we're thinking about things called social determinants of health. And, really good integrative treatment not only treats addiction and the psychiatric, but with the same team in the same location at the same time, but they also work with the client to complete overall health. So the whole person. So that's what we want to talk today about, is the whole person and ways in which treatment programs can do that. Throughout this presentation, you might notice that, I speak a little bit more about the sort of larger macro type of concepts. And you'll find that Vaughan will talk more about the micro level, sort of the clinical applications of things. And that is not a mistake, that is by design. So we're hoping that getting both of those perspectives will be helpful. So who are we talking about when we say folks who need integrated treatment?
Thanks, Soy. So just again, to kind of lend a little bit more context to this is some data. This is from 2018, looking at the overlap between mental illness and substance use disorders. Historically, in the United States, we've really treated these two different types of illnesses in silos. So for people with mental illness or mental health disorders, we've sought psychiatric treatment for them. And then for people with substance use disorders, we've provided addiction treatment for them. But what you can see here is there's a large amount of overlap, over 9 million. I think probably it's even larger than this in terms of the overlap, especially if we looked at the past year. But what we're really talking about today is how to integrate the treatment for these two things, because we know they're so related. And clearly sort of the statistics also support that. So one of the things we want to do first is actually let everybody participate a little bit through what's called a live poll. And we're going to create a word cloud together about the word recovery. So whatever word, phrase comes to mind for you, you can actually participate here. And as people start participating, we'll see it show up on the screen. So the way this works is you'll text a word, phrase, to the 22333 number and include the code. And actually, I'm going to participate too, and we would invite everybody to kind of send something in, and we can kind of really see what comes to mind for everybody in when we think about just the term recovery. And I hope it works because we did test it out.
And you know, when it works, what we'll probably find as well is that if somebody's using a same word, the word will get bigger on the screen.
Yeah.
So that's pretty cool too.
Okay, so we've got hope.
We got hope. So we got, let's see what else people, and if you're having problems with it, just, you know, unmute yourself and let us know. Yeah.
Looks like somebody's worked.
Connection, awesome.
Connection. And I think that you have to put the code first, followed by your message.
That is correct. Yes. Community. Oh, this is great. All these words are going to be in the presentation.
Yeah. And you can see hope is getting bigger.
Yeah. That's really resonating with a lot of people, I think. Yeah. Awesome.
Oh, got another one. Yep. Hope and community. Resilience. Love that.
Yes.
Lifestyle.
Okay. Relapse. Okay.
Struggle. Yeah. Okay. Somebody put in choice. I like that one.
Mm-hmm. Awareness. Is that self-awareness?
Maybe.
Yes, yeah. Self-awareness.
Yeah.
Okay, great. That's a good one. I like that.
Awesome. Well, thank you, everybody. We're going to do one more of these in just a minute. You can keep participating, and we can probably come back to it at the end and kind of really see where the word cloud ended up. So this is great.
All right. So, so when we're thinking about recovery, we're, you know, I mentioned in the outset of the presentation that we're talking about whole person perspective, a whole person recovery. So when we think about recovery, we think about these 4 areas. Choice, which someone put in that word cloud, which is awesome. Connection was also in the word cloud. And then there's stability and access. We're going to go through each of these. They're actually going to have their own slides, and we'll go into depth. But I will just tell you now that, you know, we think about recovery, we think about that the client should be empowered to be socially connected back into the world outside of treatment. And this should be supported by having access to treatment with the emphasis on stability and consumer-driven goals. So when we think about choice, we think about really this idea of consumer, the clients sort of in the driver's seat of their goals. You know, the idea is that the social conditions in which, you know, the consumer sort of walks into your office or into your program should not be ignored. And that, you know, there is social disconnection oftentimes that happens with treatment if it is ignored. And we have to really sort of rectify that and make sure that the client, you know, is able to basically connect in some way back into the real world. So when we think about recovery, we're really thinking about these areas, and we'll go more in depth. So what does recovery and change have in common?
People might be familiar with this sort of commonly used definition of recovery that is about a process of change, right? It's not just sort of a one-time change. It's the ongoing process of change focused on sort of health, wellness, self-directed life. Now, you know, I have abstinence on here and I want to talk about that for a minute. We do know that abstinence or abstaining from a substance represents the most stable form of remission from a substance use disorder. However, we also know that abstinence is not the defining feature of recovery, right? There's many other components and parts of recovery and, you know, health, wellness, engagement, relationships, improvement. And for many people, abstinence from a substance or behavior is part of that, but also for many of our clients, it is not. And so sometimes when we're working with co-occurring disorders, that also means sort of tolerating and working with them around reducing harm or developing a moderation plan if that's really where they're willing to start, because ultimately recovery is self-determined and self-defined.
Right. So now this slide may be a little provocative, but I want you guys to kind of hear me out with this one. So we all know about overt ways to dehumanize. Well, we should at least be aware of it. We just had a national holiday for the first time, Juneteenth, right? However, oftentimes we don't really talk about the subtle ways in which dehumanization can play itself out. So, you know, when you take away choice or decision-making from a person who is, you know, displaying addictive behaviors or psychiatric instability, when you withhold psychiatric treatment or vital case management from a person because they're using substances, when you ignore medical needs or deny medical care because the person's using substances, when you socially isolate or ostracize a person because they're using substances. I mean, these are all things that have happened and continue to happen. What all these things have in common is that our behavior towards them promotes a form of dehumanization and domination to certain parts of their human existence, right? So our role should be about liberation, the opposite, which is this idea of the opposite of domination, which is the idea that we should be helping them free themselves from the psychological and social barriers that promote them to be free to live the healthy lives that they want to. So we have to really think about, you know, why whole person care, looking at the social conditions are important and not sort of replicate subtle forms of dehumanization. So let's see what comes to your mind now when we think about connection. I think this is when we're going to do another word cloud. Perfect.
Yep. Perfect.
All right. So you guys are pros at this point. So connection, what comes to your mind when you think of connection?
That's right. So the number to text to 22333 will be the same. You'll just use a different code with your word or phrase. Community. Yeah.
Relationships, yeah.
Yeah. Interdependence, okay.
Healthy's on there too, Vaughan.
Yeah, I like that. And I like authentic, right? Because that is what we're talking about.
Right. The relationship is just getting bigger and bigger.
We're going to talk about that.
Yeah.
So I really like it. Oh, somebody put in trust. I think that's great too.
Yeah. Interdependence, community, yeah. I think these word clouds are so cool.
Yeah, this is so awesome to see everybody doing this.
Yeah.
Awesome.
Environment, yeah.
All right. This will stay live as well if anybody wants to keep participating. And then really, I think we can keep going. So and really let you define also connection for us and how we were thinking about it for the presentation.
Sounds good. Yeah, so I mean, I think all of those things are, that was in the word cloud are definitely all relevant. When we think about connection and integrative care, we think about obviously community. A lot of PAC programs are about psychosocial rehab, integration into communities. But it's also a community, I think, in terms of, you think about the recovery world, right? A community in recovery as well. So community can be broken down in so many different types of groups, but it's this idea of feeling like, you're part of a group that is supportive. The other thing that we often talk about is just having some purpose in life, and that's a connection, right? That's connection to your own personal value and the social value. We kind of see a little bit about, outside how people treat people who are, not working, for instance, or, in any way of sort of taking outside of the traditional sort of norms. And so regaining a purpose, regaining a meaning is all connection as well. So when we think about connection, we expand it to mean all of these things. And so to us, it's important to go a little bit deeper into this connection and how we can sort of develop or help a client develop this connection in a clinical setting.
So what this might look like in practical terms, and I think this showed up in the word cloud, is really first focusing on that therapeutic relationship, right? That sort of helping relationship that is based on authenticity and trust. We know from lots of research that therapeutic relationship is really kind of one of the key factors in terms of whether or not somebody benefits from treatment. So that is a key part for integrated treatment. Also really focusing on what the client's personal values are, where they derive meaning, and what is going to make their life worth living. So coming back to sort of the connection, and we're going to talk more about choice as well in terms of like really their personal values. And then also providing non-judgmental listening and support. When we think about co-occurring disorders, there's a lot of shame and stigma surrounding substance use or other addictive behaviors, in addition to the shame and stigma around mental illness. And so it is really often our job just to sort of be empathic, authentic listeners without any judgment. And one of the ways that I think we can do that is not often talked about is language. So we actually have a lot of research that demonstrates that our language around substance use in particular can either perpetuate or attenuate stigma associated with substance use. And what this looks like for us in our treatment settings is actually being really thoughtful about the language that we're using. So we're not using any terms like substance abuse or substance abuser, because that actually originates from sort of a moral conceptualization of substance problems, and can really be incredibly stigmatizing So we're using sort of more medical and recovery oriented language with both our clients in our team meetings and also with family members and sort of other providers as well, sort of modeling what sort of less stigmatizing language might look like. And that allows the client to determine how they want to identify and what language feels sort of useful for them. I do like to make a distinction here between clinical language and recovery language, because as helping professionals, we should be using clinical language like substance use disorder or person with a substance use disorder. Inside of recovery communities, sort of self-identified language like addict or alcoholic might be very helpful, but that's something that an individual gets to sort of make the determination about. And so if we're thinking about connection, how we talk about substance use and the integration of substance use and psychiatric illness can actually really make a difference in being able to build that connection with our client. So let's move to talk about choice.
Yeah, so choice. So when we think about choice, it's really centered around what we say self-determination, but this important sort of model of, autonomy and empowerment. The person, regardless of how, maybe sick they are, we should be looking for places in which they can have that autonomy and have that ability to basically make decisions for their own lives. It should be wrapped around this idea that the goals that we work on should be driven by the consumer, and not driven by other forces that may be at work here. And why do we do that? Well, we think about this idea of how motivation works and all the research and what they say about motivation. I mean, if you want to get someone to basically have the ability and the desire for change, then there has to be something that they want to do. And then this idea of, even with this consumer-driven goals that you have, we want to make space for collaboration. We want to make space for your perspective as a clinician and the client's perspective to be part of this decision-making. And again, the idea is we want to foster agency and autonomy and this sense that they can direct their own lives, which in most cases can actually happen. Consumers can actually direct their own lives. And that is an important part of recovery. So let's dive a little deeper into how we promote choice in our clinical work.
Sure. I mean, so one of sort of the most obvious ways to focus on choice is through motivational interventions. And I certainly will not be doing a deep dive into MI today, but I do want to just sort of reference the spirit of MI, this idea of really sort of approaching the relationship with the client as a partnership of equals, where we are completely accepting of their perspective and their lived experience, where we're not sort of the expert just telling them what to do and maybe how they need to change, but they're the ones that are living their life and they get to make these choices, where we're really coming at the connection with compassion for those individual choices, and that we are focused on being able to evoke the client's own motivation to change instead of coming to the relationship with ideas about how they must change or how they need to change. Those types of approaches really are in conflict with the spirit of MI and with the idea of choice. And what this might look like in the helping relationship is an initial sort of heavy focus on engagement, right? I've referenced sort of the helping relationship. So focusing within the session on their sort of right to that self-determination, not arguing, going back to the language, not arguing about language, not arguing about like what term do they self-identify with, right? Not getting into these types of power struggles about how they must change. Really focusing on that relationship with a non-judgmental stance. We can do a lot to support statements that are self-motivating. And then when we focus on that sort of level of engagement with our language and the helping relationship through connection, we can also reduce a lot of the shame and stigma associated with substance use. So then what is our responsibility as the clinician? Because sometimes it can feel like, wait, our job is to help people change. But actually, here's what our responsibility is when we're talking about integrated treatment. First is to assess stage of change, to really be able to identify what stage of change somebody's in and target our interventions based on that stage of change. To work with them to identify the barriers to change. So is this an issue of willingness to change or ability to change? And what resources, and we're going to talk more about like access and stability, but really what are some of those barriers? We can definitely use clinical techniques to develop and reinforce motivation to change. We can work with the client towards their self-identified recovery goals. So it may be starting with a goal that's not the goal we want for them, but it is a change they're interested in making. Great. If they have a change they want to make, work on that change, because that's going to build the relationship, that's going to strengthen that connection as we achieve maybe a goal that is their self-identified goal. And then we also have a responsibility to help with an accurate understanding of the problem. And so that can be achieved in a lot of different ways. Once we've got that connection and that level of engagement, we can ask permission to give feedback, right? That's a possibility. We can develop discrepancy. We can do clinical interventions to help somebody understand the problems and risks, but they get to still make that choice. Okay, I'm going to turn it back to Zoya to talk about stability.
Thanks, Vaughan. I also want to just add about the engagement piece. That is so powerful, because when we think about stages of change, I think, you know, what you're sort of talking about is all the work that has to happen before we even start planning, right? We have to really engage a client in ways that they're understood, but also in ways they're not judged for what their behaviors are. And so oftentimes you think about programs, they kind of skip that and go right into planning stage about, you know, this is what you need to do. You got to go to these meetings, you got to do all of that. And we're really talking about putting a lot of work up front. So I totally appreciate that. So one of the things that we talked about was stability, right? And so, you know, stability is a loaded word. It can mean many things for different people. When we're talking about stability, we're going from not just psychiatric stability, but we're also talking about just like things like basic needs. You know, I often, you know, if a client is in my office and, you know, they haven't eaten all day, it's going to be kind of hard for them to do any sort of real cognitive work with me, or, you know, or if I'm at their home. So, you know, we have to think about stability in terms of basic needs, stable housing, consistent community supports, things like that. All these things are really important to drive recovery. Yeah, so there's different ways of thinking about stability, but we're talking about the whole gamut of things, and that's really important. So let's dive into how we promote stability in the clinical setting.
So sort of some of the application here when we're thinking about psychiatric symptom stability, because we know how sort of related that is to substance use, is to really explore the relationship between these two things. Sometimes when clients come in, it may seem really obvious to us, the relationship, for example, between their trauma and their substance use. And we can kind of see when we get a history from them how these things are related, but they may have no idea how these things are related. So we can try to understand for ourselves in the work, but help them also understand how are these symptoms related. And that also means sort of challenging some of our perceptions that substance use might have actually been the only thing keeping them stable for a period of time. It was the only thing that maybe did help them manage their symptoms. And that's going to give us some insight into why people might be reluctant to change if that really was the only thing that was working. So we really want to work together to understand how these things are so intertwined. Like Zoe was saying, sometimes the work is also just really focusing on actual resources. What types of referrals, linkage with community resources, other providers do I need to help this client with? Again, going back to, is it an issue of motivation or is it an issue of ability? And until maybe I help them meet some of these other needs, they might not be able to make the kind of changes that we're talking about. So we're working to reduce some of those barriers to treatment and to recovery. The last thing I'll say in this category is about really kind of our obligation, and I think it's really an ethical obligation to engage clients around the topic of substance use, even if that's not your area of specialty. Clients are often really reluctant to disclose drug and alcohol use or other addictive behavior to mental health clinicians due to sort of fear of sort of being asked to make changes, due to stigma, due to shame. But that can really make it very difficult to actually address somebody's psychiatric symptoms if we're not asking about and addressing substance use. So I think this falls into stability as well, because until we are also looking at somebody's substance use, we can't really expect their psychiatric symptoms to be stable. So there really is quite a strong relationship here between these two things. And I will turn it back to Zoe to talk about access.
Yes, so this is our last sort of major component to whole person recovery is access. Really important in integrative treatment is this idea that a client should still have a pathway to access the treatment, regardless of where they are in their recovery, right? Regardless if they're using or if they're not using, they should have access to treatment. And I know that is, not the way the traditional model worked, right? In many ways, it was sort of like, no, you have to be, sober in order to get psychiatric care or to get these things. But in true integrated treatment, it's about you're meeting a client where they're at and they have access. You are able to kind of, and we're talking more about it in the clinical applications, but you're able to try to modify what you are giving depending on where they're at. So there are multiple pathways to recovery and resources because we start with this understanding that, we're giving access where people are at different places, right? So there's going to be multiple ways to get to the recovery. Part of access is also reducing the barriers that will prevent them from getting treatment. Sometimes that means, obviously going to where they're at, removing the stigma, big one, and community-based work. What does that mean? That means that, wherever they are in their community, we have to help the clients gain access to, to resources in that community. And understand that it's not just about the resources that we provide, but it's also about the resources that they can get in their natural environment as well. So these are all things, that are important around access. But specifically, what does multiple pathways look like?
Yeah. Okay, so let's talk about what are those pathways and how do people actually recover from substance use disorders? We have a lot of research on really kind of what works and how people recover. I won't go in depth about all of these, but I do want to touch on a couple of them. The first being what natural recovery is. Those are people that recover without any sort of intervention. They don't go to a support group. They don't get any clinical intervention. And those are people that when sort of in nationally representative surveys, they say, I've resolved a problem with drug and alcohol use, and it's not a problem for me anymore. We're talking about a little bit more clinical intervention, but I think it's helpful to have that context that there is a population like that out there. Sort of in terms of treatment approaches and recovery pathways that we commonly refer to, and you're probably the most familiar with, are 12-step pathways like AA and NA. And these are very commonly utilized and referred to. And I just want to sort of say that they do work. Right? The research says that they work. And going back to really our theme of connection and access, these are the most sort of available, right? Access, where people are, they're most commonly used because they're sort of the most available and people have the most access to them. And connection, because we actually, all the research we have about why 12-step pathways work is about the connection, typically the connection between the individual and their sponsor, and that helping relationship that's reducing stigma, that's got sort of a shared experience. That's really what tends to keep people in those programs and really make the difference for them. Now, we also know that a lot of people are not interested or have sort of had a negative experience with 12-step pathways, and there's a growing number of non-12-step mutual aid programs available. That might be things like Smart Recovery, that could be things like Refuge Recovery or Life Ring. So there's a lot of options out there that sort of use a mutual aid approach that are not 12-step based. So we're talking about this in terms of access, because if somebody has a an obstacle to 12-step programs, there's lots of other resources and things that you can refer them to. Obviously, we're talking a lot about clinical interventions today and community integration, but there's also peer recovery support services. I know both at Menninger and Ellenhorn, we have integrated peer recovery support services into our program, but this is, for those of you that are not familiar, a sort of a certification for individuals with lived experience who are really trained and become experts in how to use that lived experience to walk along somebody in their own change process. It's sort of also like a really growing area of research that shows this is quite a promising intervention. And then finally, I'll just touch on internet-based support, again, from the perspective of access, that if somebody has childcare issues or transportation issues, or maybe they want to do Smart Recovery, but there's no Smart Recovery meetings in their community because they live somewhere rural, the internet really makes all of these things available to people in ways that we did not have before. And so there's a lot of smartphone apps, sort of online communities, forums that people can use. And all of these things work, and any combination of these things can work. I also want to touch on like what they have in common and like how they actually help people, because I think this really illustrates all of the things that we've been talking about today in terms of choice, stability, access, and connection, right? Support groups are focused on a safe, shared space, helping relationships and exchange of knowledge between people, again, that have shared experiences. There are sort of resources that are focused on personal change, not just on abstinence. And then really all of these support groups also have online components so that they are accessible. So there's quite a lot of commonality regardless of sort of what approach or pathway somebody is interested in. And then finally, when we're thinking about access, the idea here is that the best recovery pathway is the one that an individual is willing to pursue. So the changes that somebody is interested in making and willing to make, that's the best thing to support them in doing, as opposed to getting caught up in what we as sort of helping professionals think they should be doing differently. Really by providing exposure to sort of all of these different pathways and resources allows us to really adhere to this idea of choice, that an individual should get to select a program and a recovery pathway that aligns with their values, their beliefs, and their goals. And like we said earlier, that goal might not be complete abstinence, for life. And the last thing here is that why people sort of benefit from support programs is not specifically about the pathway. Typically, it in a community integration setting, in a recovery support program, in a mutual aid, it's an increased support overall, an increased support for change of some kind. If you're in a recovery community, there's a support for some type of change, and then there tends to be a decreased support for using substances. So it's all of these things combined that really are the mechanism of change when we think about recovery pathways. So I think that might be we got one more slide, so I'll turn this back over to you.
Sure. And I also want to add to the last slide, it's also an acceptance of where you're at, right? A lot of those recovery spaces are also very accepting of where people are at. And so that's really important. So this is just basically, a sort of recap of what we talked about, which is choice, connection, stability, and access. And I think with this slide, what we really want to focus on is this idea that, as you notice, a lot of this stuff doesn't occur in the office. I'm a big component of this idea that if you think all the work happens in the office, then you're kind of missing a big piece of this. And also a lot of this has to do with what the client is willing to do. And so that's super important. And especially when you're thinking about integrative care, you're thinking about this person who has multiple parts to them, and that, that in many ways, we're not going to be able to determine which part they want to work on and which part they don't want to work on. But what we can do is make sure that when they're, ready and able to engage with us, that they have the access to it, and that we can form the connection to them. So that's sort of like our version of saying, look, integrative treatment is not a big secret. These are ingredients. We all have it, and we can all, as clinicians, really apply these things to our clients.
Yep.
So,
You're actually right on time. Now we have time for questions.
Question time, Q&A.
So the only question we have is, will we be able to get a copy of the slides? And the answer is yes. I will be sending out a follow-up email after the presentation with the slides and a recording of this webinar, as well as contact information for Vaughan and Zoe if you happen to think of any other questions after the webinar. But at this point, please feel free to unmute yourselves, turn your camera on, and ask any questions or any discussion you may have.
I will say, we recognize this is an overview, a very brief overview. And I think each of these sort of concepts, we could have gone way, way more in detail. But in some ways, it's almost like not giving total justice to integrated treatment, but hopefully you guys get a good sense of the kind of work that we do on a daily basis with our clients.
I have a question. I'm curious, what are your, I have a question. What are your findings or research on engaging the family, particularly when we look at the concept of connection and community outside when they leave the treatment, and at what stage at either facility do you engage in and start the process of support?
It's a great question. Vaughan, should I go first? And I can go first.
You can go first, yeah.
Okay, that's a great question. I think it's highly individualized. I mean, I think in an optimal situation, you have families engaged right away, right? Because families are usually, in most cases, a primary support system. And the idea of engaging them right away is, if there is most likely there is, if there is a communication dynamic or a behavioral dynamic, you want to be able to kind of be able to provide coaching right away. But also you want to be able to let the families know that they have a role in all of this, right? It's not just about dropping someone off the treatment and then they come back and, to you, fine. It's about the system changing, right? Because, yes, the client's identified patient, but the patient is, working within a system. And so if the patient's going to change in the system, then everyone has to change. Not only change how they view that client or their loved one, but also change in ways in which they communicate and how they sort of react. So I think in optimal situations, there will engagement right away. I think it's individual because you don't know what kind of family systems is working there, and you may have to, bring the parents in or maybe bring other people in that are not the parents initially.
Yeah, and I would add, I think many of the concepts that we're talking about today in terms of focusing on engagement, starting where they are, like those apply to families as well, right? A lot of the motivational interviewing techniques, motivational interventions are applicable for families as well, right? they may be often the catalyst for the loved one coming to treatment, but they also may not really want to do their own work and make any changes to their own behavior. So I think family therapy, we do a ton of family therapy, because I think the family therapy is about like, how are we making changes in the system, and how are we delivering some of these interventions to the family as well, because they are going to also need to probably make some changes and be ambivalent about that. I hope that answered your question.
Yes, thank you.
It's a great question.
So we do have a question from the chat. Joseph asks, how would you talk to colleagues who feel like they're not able to work with clients who have substance use disorder problems?
That's a great question. I know Vaughan and I, we've talked about this before. So go ahead, yeah. You could take the lead on that, Vaughan, and I can.
Yeah, I mean, I think what I would say about that is, I would be curious first if it's that they don't feel like they're able or they don't want to, because I do think there is a distinction. I mean, there's research on sort of the general negative attitudes of health professionals towards individuals like with addictive disorders. So, you know, I'm kind of would be curious about like, which one is it? If it's like maybe not feeling confident. In my interactions with colleagues who maybe don't feel confident working with substance use disorders, a lot of it is actually some of the stuff we went over today in terms of helping them apply a lot of the techniques they already know around like self-determination and engagement to those types of clients, because actually a lot of the skills they have are pretty transferable. If it's that they really don't like working with those types of clients, then actually they probably shouldn't, because they might actually do more harm than good. I don't know what I would say, but that's what I would say about that.
Yeah, I mean, I think it's become one of the, certainly in the primary care field now, more and more primary care doctors are actually being trained to ask really simple questions. So the idea behind it is that you can come in substance abuse work in different ways. You don't have to come at it in a way where, you know, someone's able to kind of work with someone from start to finish. However, if there's a relationship there, you don't want to miss the opportunity to explore it. So what we all have is this our natural curiosity, but we also have this gut instinct to say, hey, you know what, this is crossed over a place where I don't feel comfortable handling. And that's totally fine. I think this goes back to what we talked about, access, because part of it is accessing for yourself the appropriate referrals. So if somebody comes in and you're noticing there's a little bit much more substance use stuff that's going on, and your curiosity has sort of reached the limitation, then knowing who to refer to becomes really important. And sometimes if that's the only thing you do is just knowing who to refer to, but also keeping that client sort of engaged to the next step of the referral, which we all as clinicians can do, is this idea of saying, all right, I may not be the best person for you, but I know somebody who can, and this is really important, and I understand what you're saying. Then if that's where you're at, that's beautiful. You know, I think that's really good stuff. Yeah.
Any other questions? You can put them in the chat.
Ivana asks, what are the unmet needs in research today pertaining to integrative treatment for co-occurring disorders, for substance use disorder and other mental disorders?
I mean, I could say there's a lot. I mean, there's a lot of research that needs to be done. You know, especially when it comes to like, you know, we think about addiction. We also think expand it to behavioral addiction. And you know, how do you integrate behavioral addiction with mental health addiction and things like that? I think there's a lot of research to still be done on that. I think there's a lot of research on certain demographics that are not, you know, researched enough on. Unfortunately, a lot of the research sometimes is driven by pharmaceutical companies, And pharmaceutical companies have their own biases because they want to make sure that they get good results for their medications. And sometimes in the sort of zeal to get good results, they actually have a very sort of limited scope on who they actually ask to, who they actually research to take their medications. So I think where the research is coming from is really important. So I think we're sort of, it's become more accepted, but I think there's still a lot more work. And then of course, there's a lot more work in terms of the federal, like government's, their sort of research policies on certain substances that may be Schedule 1. I mean, we haven't even touched the surface of what, cannabis, in terms of cannabis research and things like that, that in a lot of states is now legal because of a lot of the federal sort of limitations to research that. So anyway, that's just what I think. What do you think, Vaughan?
Oh, this is complicated. I would echo that. I think like a lot more research in terms of how we diagnose and treat behavioral addictions and what even classifies as a behavioral addiction, definitely. I think there's a lot of unmet needs in terms of, like, we know, like what we're talking about today, that integrated treatment is effective, but I think there's a lack of translation from research to practice in that area, where a lot of addiction treatment centers like hire like a contract psychiatrist, and then they say we're co-occurring, but all they're really doing is 12-step facilitation, and they're not actually doing co-occurring disorder work. I think the same thing is true for like mental health treatment, that like we have 12-step meetings, therefore like we're co-occurring. So I think there's a lack of translation there of research to practice. And then I also think in terms of like what it means with the legalization of cannabis, and like, for example, we really don't have good research yet. Can somebody resolve an opioid use disorder and still use cannabis? And like, what are sort of what's the long-term trajectory sort of some of these types of things? Yeah. Lots to research.